Afternoon, everybody. My name's Stephen Radley. I'm a urogynecologist at the Jessup Wing, Sheffield Teaching Hospitals. Declaration of interest. I'm involved in a spin-out tech company called EPAC, and that's also owned by Sheffield Teaching Hospitals. So I'm going to talk to you about prolapse and how we assess and conservatively manage prolapse in primary and secondary care, and also think about the mesh scandal and also how things have evolved during and since the pandemic. So let's see if I can progress this. So learning objectives, I think you'd like to have some things to think about. How we assess and pelvic floor disorders. Think about being more aware of conservative management options and how patients can help themselves. Reflect on the mesh scandal and what's gone on in mesh services or going on in mesh services, and also how COVID has affected women's health and pelvic floor disorders in particular, the management. So a brief sort of summary. It's obviously obvious and we know this, but for pelvic floor assessment, it's all about history and examination. It's all about the clinical assessment, and we do have some laboratory tests which we can allude to, but it's all about seeing and examining our patients. We know this. In terms of pelvic floor disorders, it's quite useful to have some structure for how we go about symptoms assessment, and this is the structure we like to use: bladder, bowel, vaginal and sexual, and they often coexist and they often interact with each other. So it's unusual to have just one condition in isolation. So just because somebody comes with some urinary incontinence, think about prolapse, think about bowel function, and think about sexual function as well. Not always easy to assess pelvic floor disorders for a number of reasons. It's well known that symptoms, particularly prolapse symptoms, correlate poorly with physical findings. So women with large prolapse often have mild symptoms. Women with mild prolapse often have severe symptoms. And there's a variation between observers and even between the same observer over time. So quite often I'll examine a patient in clinic and find mild prolapse, and then on the operating table or in the next clinic visit it seems more severe. So there's a lot of variation. And also we tend to have a slightly non-standardized approach to how we describe symptoms and findings. So any improvement in that might help in communication with patients and amongst ourselves. So we know that women who do have prolapse have more pelvic floor symptoms than those without prolapse. But as I said, the grade of the prolapse doesn't actually correlate with the severity of symptoms, except for maybe vaginal lump symptoms. It's obviously important to ask, but it's a relatively poor correlation both before and after intervention. I sort of quite like this sort of mathematical model of how we think about the sort of working diagnosis. And that top right-hand image, the pie chart, really mirrors what I've just said, that it's mainly about the history and then the examination giving the bulk of what we understand about our patients with pelvic floor problems. And then we have other things like bladder diaries, urinalysis, urodynamics and questionnaires and so forth, which supplement that. But it's principally about the history and examination. However, there are some patients, bottom left here, where communication is difficult because of either language or comprehension or whatever, and actually we can't rely so freely on the history, and that's when we tend to rely more on other tests or assessments like questionnaires, for example, like urodynamics, for example. So I quite like that approach, and but even so, there's no sort of gold standard. I think the diagnosis, the working diagnosis, is a composite of all these factors, some of which you obviously have in primary care, some of which are in secondary care. So there's not a single gold standard, apart from to say that history and examination are paramount. I'm not sure where that's coming from. Anyway, so what symptoms do women with prolapse have? There's a typical something coming down below, which we use or abbreviate to SCD. Vaginal symptoms: pain and discomfort, vaginal lump, impact on capacity, quality of life, and sexual function, as well as associated pelvic floor disorders such as bowel, bladder, and bladder function. So those are the standard symptoms. And they have those primary effects of prolapse: the discomfort, the bulge, the protrusion. but also the secondary effects, the feeling of being less attractive, the effect it has on body image and perception, embarrassment. It's a taboo subject and difficult to talk about, and sometimes our interventions can have negative effects on quality of life, body image, etc. Sexual function is probably one of the most important aspects for younger women. Difficult sexual penetrative sexual activity or dyspareunia, reduced frequency of sexual activity and reduced enjoyment, feeling inhibited, withdrawing from sexual activity and avoiding sexual activity, well known to be affected by prolapse in particular, but pelvic floor disorders in general. Particular vaginal symptoms which are associated with, they're not necessarily causally related to prolapse, include dryness, so dyspareunia, difficult sexual function, tightness, avoiding partners, avoiding them, anxiety, and so forth. So for some women, sexually active women, these are of far greater importance than for others, and it's important to appreciate how much it actually impacts on them individually, those symptoms. When look at the prevalence of symptoms, which we've done looking at questionnaire responses, the most bothersome symptoms relating to women with prolapse seem to be those of sexual dysfunction, the effect that prolapse has on lifestyle, the associated stress incontinence, and protrusion of the vaginal lump itself. Less bothersome symptoms, which are also prevalent but less bothersome overall, include abdominal discomfort, back pain, constipation, and soreness. So the top of the list there seems to relate more to lifestyle and sexual function and bladder function. So what about some of the simple bedside tests that we use? And these are the sort of things we have in urogyne clinics, and the top three there are available to you in primary care, and I recommend them to you for assessment of patients in clinics. Urinalysis, dipstick, MSU, frequency volume charts, bladder diaries, and the residual measurement of residual urine, checking patients haven't got significant voiding dysfunction. In addition, in secondary care, we have the luxury of being able to measure free flow rates, sitting patients on commodes and checking their voiding satisfactorily. And we also have routine use of questionnaires as well. So MSU, as you know, is useful for detecting nitrites, indicative of infection, leukocytes, again, infection. Blood in the urine can be signify underlying renal disease, infection, and calculus, but obviously can be a red flag for neoplasia. Protein can be a sign of renal and cardiac disease. And then our old friend glucose. Every so often I'll see patients with undiagnosed diabetes presenting with frequency, urgency, and low urinary tract symptoms, and they have obviously testing their urine can give us clues to the diagnosis there as well. So I think it's reasonable to say, but we don't always do it perfectly, is that anybody with bladder and pelvic floor symptoms should have their urine checked, and that's some evidence to support that. Bladder diaries, we send these out to everybody and they're freely available. You can get them off the internet, and I think it's useful in primary care. The most important measure is of the urine volume. You can see here, this is a 75-year-old lady with low volumes. She's going about 16 times a day. She's got large volume leakage. Her maximum capacity is around 200 mils. That's first thing in the morning. And after that, it's 150 mils and so forth. So charting that, and this is a lady with overactive bladder, and the bladder diary tells you most of what you need to know. So I commend that to you as a useful assessment. As I said, the voided volume being the most useful parameter. It's a very useful initial assessment. It can aid clinical diagnosis. It's non-invasive. In some ways, it's superior to more invasive forms of urodynamics, but it is a type of urodynamics or measurement of bladder function. And it's also critical for behavioural therapy. So when patients embark on bladder retraining, it's very useful to give them a bladder diary. They can use this to chart and measure their bladder capacities and to set targets. And actually, the act of completing a bladder diary is actually therapeutic. Patients actually notice improvement in lower urinary tract symptoms simply by filling in a bladder diary. It's a form of behavioural therapy in itself. So this is a lady with stress incontinence, a made-up name, but 40-year-old lady, stress incontinence. You can see 600 ml capacity first thing in the morning, small volume leakage. She's going about 4 times a day. So fairly normal bladder function with a good capacity of over 400 mils. And you can make a diagnosis of stress incontinence based on the bladder diary there. This is that lady with overactive bladder, larger volume leakage, smaller volume capacity, and QED, overactive bladder. Residual urine measurements. I think you have the some bladder scans in primary care. We certainly have them in our clinics here. So it's useful to check residuals with a bladder scan. If you don't have that option or that luxury, then you should have the option of an in and out catheter. And every so often patients will turn up with lower urinary tract symptoms in clinic. They don't say I'm in retention. They often describe dribbling urinary incontinence. So it's useful to check residuals either with a bladder scan ideally, but if not, then a quick in and out catheter just to confirm. And then questionnaires. We have questionnaires we use back in secondary care, and we're able to assess patient symptomatology. This is a long 120 item questionnaire, which takes about half an hour for the patients complete. Most do it online. There is good evidence that questionnaires are useful, and I appreciate they're not always available in primary care, but the prevalence of symptoms such as coital incontinence you see here detected with questionnaires are around 60% or 50-60%, whereas if you just use direct questioning, you can see it's down at around 10 or 12%. So if you're interested in intimate urogyne symptoms such as coital incontinence, fecal incontinence, and so forth, there's no doubt whatsoever that using a well-designed questionnaire is very valuable. And these are the domains of the questionnaire: bladder, bowel, vaginal, and sexual symptoms, which form the assessment that we talked about at the beginning. I got interested in questionnaires because of this operation we were doing back when I was a senior registrar, doing sacral colpopexies using mesh back at the old Jessup with Val Brown, and we were looking at this operation, and there was no good outcome measures. So we started working on this questionnaire to assess patient symptomatology before and after intervention. And that sort of triggered my interest in patient quality of life assessment and questionnaire use, which is what we see here, where you have all those 4 dimensions of pelvic floor symptomatology, and at the bottom you actually have a comparative, able to compare before and after intervention. So that was sort of my background to those interests in particular. My photograph of the desk, where you have the GP's letter, you have the frequency volume chart, and you have a questionnaire to assess pelvic floor symptoms. Okay, so that's how we go about assessing patients from a symptom perspective. Examination usually involves, well, if you have it, then a sim speculum examination combined with a valcellum sponge forceps to examine the vaginal walls. And this would be the patient in the left lateral or Sims position, supporting the anterior right leg there with a helpful nurse, and then usually retracting the anterior vaginal wall and inspecting the posterior vaginal. Right, so vaginal examination, sim speculum, and then grading of prolapse. So we can look at the grading of prolapse in terms of mild, or the normal position where the cervix and the vaginal walls are naturally supported. First degree, where there's descent to mid-vagina, that's often called mild prolapse, or second degree prolapse, which is visible or present at the level of the introitus, and then third degree or severe prolapse, which protrudes to an extent. And then we have the more severe form of procedentia, where there's complete uterovaginal eversion. Everything's turned inside out, if you like, on the outside. So clinical findings: prolapse nil, 0, mild first degree, moderate second degree, and severe third degree. And that applies to whether you're describing the cervix, uterus and vault, the posterior wall, or the anterior wall. There's a more complex form of description of prolapse, which I don't think you need to know about, but it's used this POP-Q grading system, which is describes the degree of prolapse in centimeters from fixed reference points. I'm just mentioning it here because it's something that we do talk about, and we just document things more accurately. It's a more advanced form of grading for prolapse. It's called the POPQ system, and it's an international standard for measuring the severity of prolapse. And we have these grids which define the prolapse in 9 defined areas based on reference points in relation to the level of the hymen and descent and centimeters above and beyond that. So just to summarize, the assessment of prolapse is unreliable in terms of symptom assessment, variable and somewhat subjective, but symptoms are the most important measure of the pelvic floor condition. We do need a systematic and comprehensive assessment of symptoms. Signs are also variable and subjective, an important measure of structure, and we need to be able to document and describe those. In terms of management, in primary care and secondary care, I think it's always worthwhile starting with what patients can do themselves, the most sort of conservative things. And we know that smoking, obesity, high caffeine intake and bowel dysfunction can all be associated with pelvic floor dysfunction. And there's a good evidence base that weight reduction, stopping smoking, reducing caffeine and avoiding straining and constipation can all be beneficial. So it is worthwhile saying to that, and often have that conversation with patients, that sometimes there's more that they can do to help their condition than I can. I think we often send patients to physios. Can physiotherapy treat prolapse per se? I think the answer is probably not. Doesn't actually treat the prolapse or re-support the vagina, which is usually due to ligamentous problems rather than muscular problems. But should patients with prolapse be referred for physio? Generally, yes, particularly those with mild prolapse, patients with pelvic pain, bowel, bladder, and associated sexual dysfunction. So we do send patients along to physio with mild to moderate prolapse for those very reasons, but not because it cures the prolapse. I think that's sometimes a bit misleading to suggest otherwise. What about HRT? We give out an awful lot of vaginal HRT in clinic. Can HRT treat prolapse? Again, no, same as applies to physiotherapy really, but should we offer HRT to patients? Yes. Again, those patients with symptoms of mild prolapse, pelvic pain, dyspareunia, vaginal dryness, etc., and associated sexual and bladder dysfunction, all of which have good evidence for the efficacy. Much better evidence relating to vaginal HRT rather than systemic HRT. What about pessaries? I'm sure you're all familiar with ring pessaries in primary care, which are generally widely available, and I think certainly a therapeutic trial of a ring pessary in primary care is entirely appropriate. How to find the right size can be a degree of trial and error, and it's down to experience really. But I think sometimes you can try 2 or 3 pessaries before you hit on the right one. Ring pessaries have the advantage of being soft. They're relatively easy to insert, and patients can remove and replace them themselves. We also have the shelf pessary, which is the bean-shaped firm plastic disc with a stem that points downwards, which helps to keep it orientated in the vagina. And similarly, Gellhorn pessaries, which have this similar central peg. These are made of a softer silicone rubber, and they sit inside the vagina, and you can see why this would preclude penetrative sexual activity, and also far more difficult for the patients to change themselves, although I do have 1 or 2 patients who change their own pessaries. And occasionally we have patients who we try a cube pessary. Again, these are self-changing, and this string here allows the patient to put in and replace the pessary themselves. These are quite expensive. There's only 3 different sizes, but we do have them available in the Jesset wing for patients in whom these other pessaries are either unsuccessful or inappropriate. So yes, that's the option of pessary, and increasingly we're encouraging patients to manage themselves with these pessaries. So self-management is mainly, though not exclusively, related to ring pessaries. How often to change them? Well, there's no strict rules about this, but I generally say, well, why don't you take it out on a Friday evening and put it back on a Saturday morning? Remove and replace prior to and following sexual activity, and also potentially combine the use of a pessary with topical HRT, which can reduce vaginal soreness and improve sexual function. So there's evidence that vaginal estrogen can help, particularly in postmenopausal patients using ring pessaries. And the other thing we do for patients who are self-changing and self-managing their pessaries in this way, with this appropriate support, is give them open access to our clinics. So we have patient-initiated follow-up, which we introduced in urogynae during COVID, actually, but has become very successful, and it works well for patients who are self-managing their conditions, particularly self-managing their pessaries. Where do I come in with prolapse surgery? Well, the lifetime risk of having prolapse surgery is about 11%, maybe as much as 12% now. So it's a fairly frequent operation carried out here in the NHS as well as in the USA, and about a third of patients now will have more than one operation. So it's the success rate, if you think that's a failure rate of maybe a recurrence rate of approximately 29-30%, is not all patients are successful.
I mean, it's some of it.
When should you have prolapse repair? Well, when symptomatic, if patient's bothered by the prolapse, symptoms such as sexual dysfunction, discomfort, obstruction of bowel and bladder, and obviously if they're bothered by it. If it's mild or moderate, then prolapse doesn't usually require fixing, or you need to be careful before you recommend surgery with patients who are otherwise relatively asymptomatic. And though obviously if the prolapse is protruding grade 3 outside the vagina, becoming ulcerated, and if the conservative measures are proved unsuccessful. Sacrospinal fixation is used for patients with recurrent prolapse. It's probably not relevant here actually, but the sacrocolpopexy I mentioned, and I'm coming on to mesh repairs now and the lessons from mesh. That sacrocolpopexy was introduced as a method for treating recurrent prolapse of the vault after previous hysterectomy surgery, and the driver for this was based on the general surgical experience with inguinal hernia repair, where it was well known that the recurrence rate with conventional sutured repair for hernias was approximately 5% before the introduction of mesh. Sorry, it was 30% before the introduction of mesh, and dropped down to 5% with mesh repairs. So we, the gynecologists, thought it might be a good idea to try and use meshes for augmented prolapse repair. This is the type of mesh that was used: knitted monofilament polypropylene. The literature supporting the use of mesh at the time was relatively poor. A lot of the data were observational, retrospective, personal series supported by industry with relatively poor outcome measures. And I mentioned some of my interest in development and use of outcome measures in the context over the years, which perhaps led to some of the mistakes that were made and some of the problems that arose following that. In terms of what meshes are and what they look like, most meshes were blue, or a combination of blue and clear polypropylene. You can see the open weave there. On the left hand side you've got the TVT mesh and the blue strip, and on the right hand side you've got the much larger vaginal mesh that was used for augmented vaginal prolapse repair. Bottom left you've got some blue mesh protruding into the patient's bladder and some bladder stones forming around that. And on the right hand side you've got a clear polypropylene mesh protruding into the vaginal mucosa, which feels hard, looks and rough area in the vagina. So these were introduced over approximately 20 years ago, and as you know, became withdrawn due to mesh complications, particularly those relating to some of the newer meshes put in for vaginal mesh surgery. So TVT was perhaps the best evidenced treatment for stress incontinence at the time, though to some extent was taken out when it was felt that any form of vaginal mesh, including those for prolapse, were deemed inappropriate. So we're no longer in the UK allowed to put in TVTs for stress incontinence. We have to do slings and copper suspensions. We're no longer permitted to put in vaginal meshes for prolapse, though we can put in those abdominal meshes for sacral colpopexy. Beyond the mesh debacle, we now have regional mesh services in which Sheffield supports the northeast of England, along with Newcastle, supporting specialist training with specialist centres, good governance, the use of outcome measures and questionnaires, of which EPAC is one, driven by the Royal Colleges, industry, patient groups, and politics, all of which are somewhat complex. And as I perhaps said, TVT was one of the best evidenced treatments for stress incontinence, and there is a move towards it coming back into practice because for a large proportion of patients, it's a good option. It's not the only option, but it's not, and it's certainly not without risks. But to an extent, the baby has been thrown out with the bathwater with the global ban on TVT as well as all vaginal meshes. And in the rest of the world, apart from the UK, TVT is one of the most popular operations for stress incontinence. In relation to COVID, we saw, like everybody, a large block in patients coming through to secondary care. In primary care, patients were not seeing GPs, so we were relatively delayed with relatively late presentation and more severe conditions. Relatively low priority in terms of the grading of surgical and medical care. Difficult to get access to see GPs face to face, and equally difficult to access secondary care, such that and patients are still increasingly using choose and book to make appointments, and often find themselves seeing non-specialists, which is particularly frustrating. So I don't know, I often see patients who've been through a choose and book system and seen non-specialists in places like Claremont on Thornbury, where I think they might be better in a specialist urogynecology unit. COVID drove, although we already had virtual clinics, but clearly virtual clinics and virtual follow-up for new patients proved popular, and was the default for a large proportion of our patients. And again, we were emphasising conservative management and self-management for patients for both in primary and secondary care. We have better developed nurse-led services, and obviously for patients with pessary management in primary and secondary care. And the introduction of patient-initiated follow-up, PIFU, has actually been very helpful, I think, for urogyne patients. So patients have greater control over their personal care in relation to urogyne conditions. So to summarise, strong emphasis on conservative management, what patients can do for themselves, adapting their lifestyles, weight reduction, caffeine cessation, the use of HRT, topical vaginal estrogen in particular, physiotherapy, not for the prolapse per se, but for associated pelvic floor symptoms. You won't cure prolapse with physio, but you can improve symptoms and quality of life and associated dysfunction. Weight reduction as can be valuable, and there's good evidence for that. And the use of pessaries, ring pessaries in the first instance. And then if unsuccessful, then let us know, and we'll be happy to see your patient.